Hey there, I'm Corey Birchman. I'm a physician. I'm the former Chief Medical Officer of Acreage Holdings, one of the multi-state operators in the U.S. with respect to cannabis. I am an anesthesiologist as well as a pain management doc, and I have a subspecialty in neuroanesthesia. My specific interest is in neuropharmacology and how drugs interact with the body, and in particular the central nervous system. I have been in the cannabis space for over 3 decades, primarily employing it therapeutically in my pain management practice, as well as studying both the therapeutic and pharmacologic effects of cannabis on the body. I assembled this slide presentation a number of years ago, and I just recently updated it and wanted to re-present it. I think cannabis has become much more mainstream since I first put out these modules as both a therapeutic and recreational product. Medical cannabis is becoming something of a staple once again in the American healthcare setting. Yet, I still think there's a huge void in educating physicians and other healthcare providers with evidence-based therapeutic guidance. And I will use the terms medical marijuana and medical cannabis interchangeably. I want to present a basic science background. I'm going to talk about the pharmacology of cannabinoids, its therapeutic efficacy, various formulations of medical cannabis, and I'll touch upon safety with respect to the patient, as well as some quality improvement items. Let's get started. As of March 2023, in the U.S., the use of cannabis for medical purposes has been found to be legal in 38 states, 4 out of the 5 U.S. territories, as well as the District of Columbia. 10 other states have more restrictive laws limiting THC content for the purpose of allowing access to products that are rich in cannabidiol, or CBD, a non-psychoactive component of cannabis. There is significant variation in medical cannabis laws from state to state, including how it's produced and distributed, how it can be consumed, and what medical conditions for which it can be used. While there are multiple references available to docs, including nationally sanctioned guidelines, both from Canada as well as the National Academies of Science, Engineering, and Medicine, there seems to be what I call an abyss of understanding. I have been contacted by hundreds of physicians over the years, frequently asking for evidence-based practice. And despite these aforementioned published guidelines, many physicians still remain uncomfortable qualifying patients for medical marijuana due to what they perceive is a lack of evidence-based literature and a lack of education surrounding the subject. I get the sense that many healthcare providers feel that a robust understanding of cannabis and medical marijuana just isn't readily digestible for them, or it takes too much time, or they have to go to a course. I think the knowledge supporting its pharmacologic basis for therapeutic use is extremely relevant. We have a huge population of literally millions of our patients presenting with chronic conditions that are self-medicating with marijuana, particularly when conventional therapies have either failed them or they believe they have failed them. And so that's basically the purpose of this series of presentations. You can think of this as a cannabis knowledge power bar. It's something small, easily digestible, and certainly purposeful. To understand the fundamentals behind why cannabis works in the body therapeutically and neurochemically, you need to have a basis of understanding of the endocannabinoid system. The endocannabinoid system is an expansive neural network. It's neuromodulatory in its action, and that means it plays an important role in central nervous system development and plasticity. It allows the CNS, as well as other body sites that I will get into, to respond to both endogenous and environmental insults. And in that framework, it is really a homeostatic mechanism. You can think of the ECS, the endocannabinoid system, as a three-legged stool. The first leg of that stool is the complex of cannabinoid receptors. I'll go into detail in a moment. The second leg of the stool, endogenous cannabinoids, also known as endocannabinoids. And the third entity are the enzyme complexes responsible for both synthesis and degradation of those endocannabinoids. You know, the history of cannabis and how it has evolved as a medication is very interesting. I want to take a little trip and tell a tale as old as time itself. Humans have been looking for and using mind-altering substances since prehistoric times, as long as they have been on this planet. The earliest alcoholic beverages date back to about 7,000 BC. Coca leaves have been found in human dental remains that are over 8,000 years old. And of course, let's not forget the poppy. Traces of opiates has appeared in human bones from archaeologic findings dating back over 6,000 years. Now, cannabis is interesting. It can be selectively bred to produce strains that have certain characteristics, non-psychoactive characteristics. Non-psychoactive strains of cannabis sativa is known as hemp, has THC levels less than 0.3%. It's a bit of an arbitrary number, but that's what they use. Nowadays, THC levels can vary in strains from anything to negligible to up to 40 and 50%. But the non-psychoactive varieties of hemp, where the fiber is, and it's grown for fiber, it can be made into rope, textiles, paper, food from seeds, oil from seeds, and other products. And in fact, hemp, interestingly, was probably the first cultivated agricultural crop. And it's been found in pottery dating back 10,000 years. Now, the first recorded use of cannabis as a drug was from about 2700 BC in China. They used it primarily for the amelioration of seizure disorders, and they used it in religious rites. Cannabis was revered. It was seen as a gift from the gods, and it was useful in analgesia, as well as in gastrointestinal disorders, anorexia, insomnia, and also in parasites, the treatment of parasites. All that changed in the mid-19th and 20th century when cannabis was introduced to the West by an Irish physician, William O'Shaughnessy. And he actually conducted really well-designed clinical and preclinical studies that were published in Lancet in the 1800s. But by the mid-19th and 20th century, cannabis was included in hundreds, if not thousands, of patent medicines, including tinctures, powders, and syrups. And they were touted as cures for gout, arthritis, migraine, cough, asthma, pain, sleep, and seizure disorders. Now, morphine was isolated from opium in the early 19th century. Cocaine isolated from coca leaves in the mid-19th century. But by the turn of the 20th century, only one compound had been extracted from cannabis, cannabinol, which is a non-psychoactive metabolite of THC. However, in the early 1940s, CBD, cannabidiol, and THC, tetrahydrocannabinol, were first extracted from cannabis. And then 20 years later, the stereochemistry and the structure was finally elucidated in an Israeli physician's laboratory, Raphael Mechoulam, in 1965. Mechoulam's lab synthesized both compounds, and that opened the gates. And since the 1960s, over 100 cannabinoids have been cataloged. This endocannabinoid system that I'm discussing plays a very important role in physiologic processes. Currently, this system has been found to be implicated in gastrointestinal function, appetite regulation, metabolic function, pain modulation, memory, imprinting, movement, immunity, and inflammation, just to name a few. The stars of the show of the system are the receptors. These endocannabinoid system receptors are G protein coupled receptors known as CB1 and CB2, cannabinoid receptor 1 and 2. CB1 possesses psychoactive potential, and it's expressed mainly in the central nervous system. In fact, it is the most common G protein coupled receptor within the CNS. CB1 receptors can also be found in the GI system, in adipocytes, liver tissue, as well as skeletal muscle. In contrast, CB2 receptors are more restricted in distribution, primarily found on immune cells located throughout the immune system, the tonsils, the thymus, the spleen, the bone marrow. Interestingly, as well, the enteric nervous system within the GI tract is studded with CB2 receptors. The activation of these cannabinoid receptors is by the endogenous endocannabinoids, anandamide and 2-arachidonylglycerol, referred to as 2-AG. It was research in the 1960s and early 70s that led to the discovery of the psychotropic effects of THC, and soon thereafter, the presence of endocannabinoid receptors. The two receptors, as mentioned, best described, are CB1 and CB2. CB1 finally cloned in the 1990s. Due to its abundance in the body, particularly in the central nervous system, CB1 has been extensively studied. Its mechanism of receptor pharmacology is quite complex. At least one aspect of its regulation is involved in presynaptic release of calcium, which leads generally to a reduced release of neurotransmitters. This sets up sort of an on-demand system in the regulation of homeostasis. And further, the endocannabinoid system is implicated in both physiologic as well as pathologic conditions, some of them including Alzheimer's, multiple sclerosis, Parkinson's disease, Huntington's disease, and seizure disorder. This figure shows the major localization sites as well as the associated functions of the CB1 receptor in the human body. The majority of CB1 receptors that are expressed in the human body are found in the central nervous system, where, as mentioned, it's involved in various neurologic activities. CB1 receptors on the peripheral side, although to a lesser extent, participate in the regulation of local tissue functions. I don't even know where to begin with respect to the CB2 receptor. Its complexity is perhaps greater than that of CB1 because it's found throughout the periphery and not in the CNS. Thus, CB2 agonism, for example, has no psychotropic or psychoactive effects. But preclinical studies have shown CB2 receptors may be useful as therapies in the treatment or management of a range of painful conditions, including acute pain, chronic inflammatory pain, neuropathic pain. As well, they may be helpful in treating diseases that have neuroinflammatory components, such as multiple sclerosis, ALS, Huntington's disease. And CB2 agonists have been proposed therapeutically to be useful in any inflammatory disorder, including atherosclerotic disease, inflammatory bowel disease, ischemia and reperfusion injury, as well as renal fibrosis and liver cirrhosis. And last but not least, CB2 agonists have shown efficacy in the preclinical setting with respect to cancer models in terms of reducing metastatic potential and inducing apoptosis of cells. If you get anything out of today's talk, let it be this. This is where the cannabinoid rubber meets the neurochemical road. The medicinal properties of cannabis can be attributed primarily to the presence of phytocannabinoids. These are the cannabinoids produced by the plant, not the human body. Delta-9 THC, tetrahydrocannabinol, and CBD, cannabidiol, are the most biologically active phytocannabinoids. The plant actually produces well over 100 of these substances, but THC and CBD are expressed in the greatest quantity, and they are capable of mimicking the human endocannabinoids AEA, which is N-arachidonyl-ethanolamine, and 2-AG, which is 2-arachidonyl-glycerol. It's this linkage, this agonism by the phytocannabinoids that is the basis for medical cannabis therapeutics. I would now like to lead this discussion towards why the medicinal properties of cannabis can be attributed primarily to the phytocannabinoids. Those phytocannabinoids being delta-9 tetrahydrocannabinol, or THC, and CBD. Let's take on THC first. THC, like its endocannabinoid cousins, 2-AG and anandamide, activates both the CB1 and CB2 receptor. And like these endogenously released endocannabinoids, the presynaptic activation of CB1 can result in both stimulation and inhibition of the elaboration of neurotransmitters. So why is this important? Why do I even care? Well, the point is that the stimulatory inhibitory effects may be one possible reason why THC has been reported to exhibit both excitatory and depressant effects in behaviors. THC can be both an accelerant, a preconvulsant, as well as an anticonvulsant. THC can induce anxiety, and it can also alleviate anxiety. I'm going to get more into the clinical implications in a minute, but I want you to look at this diagram I have on the right of the slide. In the cortex, THC affects thinking. In the basal ganglia, in the midbrain, it affects alterations in reaction time because the basal ganglia concentrates on the planning of movement. In the nucleus accumbens, THC can induce euphoria. It's part of the limbic system, as well as in the amygdala, where emotion and learning take place. THC can induce panic and paranoia. At the level of the brainstem, in the location of the chemoreceptor trigger zone, THC activity can antagonize the emetogenic nature of that center of the brain. The level of the cord, the spinal cord, it can modulate pain transmission, and therefore THC has reasonably good analgesic effects. In the cerebellar region, which is involved in motor coordination, THC can alter this coordination. And in the hypothalamus, the appetite center, THC tends to increase the appetite. And finally, in the hippocampus, the center of memory processing in the brain, THC can alter short-term memory. To recapitulate, or just put it into a different context, why is medical marijuana medical? Where's the therapeutic part come in. THC, delta-9 tetrahydrocannabinol, shares the ability of the endogenous cannabinoids, anandamide and 2-AG, to both activate and sit on CB1 and CB2 receptors. And through that neuronal presynaptic activity, it inhibits ongoing release of neurotransmitters, which then mediates homeostasis and modulates pathophysiologic conditions. It's that simple. Let's look for a moment at the non-psychoactive CBD, cannabidiol. The structure and stereochemical pharmacology of this phytocannabinoid was first described by Mechoulam in the 1960s. And it's very interesting. Initially, it was thought to act at the cannabinoid receptor, but it really only binds to the cannabinoid receptor CB1 and CB2 at extremely low ranges. And in fact, it displays such a low affinity for these receptors that, at least today, much of the pharmacologic research with CBD has been directed at seeking out and characterizing CB1 and CB2 independent modes of action for CBD. The clinical implications of CBD are extremely broad. It has been shown to have anxiolytic, antipsychotic, and neuroprotective properties. And also, basic and clinical investigators have looked at CBD in the context of other health conditions such as substance abuse and dependence, epilepsy, schizophrenia, social phobias, PTSD, depression, bipolar disorder, insomnia, and even movement disorders such as Parkinson's disease. By now, I hope you are gaining an appreciation for phytocannabinoids as they interact with the endocannabinoid system. In further slides, I will discuss why these phytocannabinoids can lead to therapeutic intent. It's important to understand that the mediating effects of THC on the endocannabinoid system depend on several factors. There are obviously other components of cannabis in addition to THC, not the least of which is CBD. And it turns out that CBD has an attenuating effect on some of the major THC effects. For example, CBD can alter the metabolic pathway by which THC is broken down into 11-hydroxy-THC. That metabolite happens to be an active metabolite as well. And so a higher THC-CBD ratio may result in more prominent psychoactivity, while a lower THC-CBD ratio may modulate some of that psychoactivity. The whole pharmacokinetic and dynamic understanding of these cannabinoids and their interaction is extremely limited, and the existing literature has multiple limitations, and further study needs to be done. This concludes this brief presentation on the endocannabinoid system. You know, the initial discovery and the subsequent extensive research over the last 30 years of this endocannabinoid system has revealed probably the most well-known, very elegant retrograde neurotransmission system. And as the main mediator of the effects of the cannabinoids, both phyto and endocannabinoids, the cannabinoid receptors have gained tremendous interest as well as respect over these years. Their widespread expression, their versatile function not only support the promise of its potential as a drug target, I think it validates the therapeutic efficacy of medical cannabis for certain diseases. In subsequent presentations, I would like to dive more deeply into the formulations and strains of medical marijuana, and look at some of the routes of absorption and administration for their patients, as well as some of the pharmacokinetic data that might serve to help the physician and healthcare provider give better care to their patient and make informed choices. And finally, in another presentation, I'll talk specifically about the therapeutic options, what diseases are amenable to this type of therapy, and where the data lies, and actually where the data refutes the use of medical cannabis. Thanks for listening.